Welcome back to the PFC Podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC Podcast. This is Dennis, and today I am where every medic fears to be, the commander's office. How are you doing today, sir?
Good, Dennis. No fear.
I'm also here with Rick Hines. How are you doing today?
Doing good. It's been a busy day.
It sure has been. But jumping into the podcast, sir, one, thank you for coming on and taking time out of your day for us. But the ultimate end goal, I think that between operational and medical sides of things, I don't really think the communications are that flat. So what I'm hoping to get out of you today is your perspective of medics, of docs, and how that affected through your time, how that affected your mission planning and things that you considered and things you knew and thought you knew. But so starting off, everybody gets a chance to introduce themselves so they can say as much or as little as they like. So would you mind doing a quick introduction of yourself?
Sure, yeah. We'll go short. So my name is Kent Solheim. Currently a colonel in the United States Army. Been in the Army for a little over 30 years. And been in SOF since 2002.
Okay, very good.
Cherry.
Yeah.
That's right. Yeah.
Well, very good. So just kind of jumping into things, when you first got into SOF, when you first got into the side of things, whatever training courses they've given you to get you ready for it, I'm confident that they told you about the different MOSs and this is what they can do and et cetera, et cetera, et cetera. So kind of what'd they say about us?
Yeah. Funny you asked that, Dennis, because actually I do remember that. You get your I think we even had like MOS days where you got to go around. It's been a while, right? But go around and experience a little bit about what each of the MOSs are and what they do. And so the 18 Deltas, you get this idea that, hey, this is your moniker of doc. This is the doc or docs if you're lucky on your team where you got two, and they're going to be not only your doc, but clearly another one of your 12 on the team. And then from a staff function, they're going to be your the equivalent of your S1. So, you learn a little bit, right? And I think more exposure comes when you go to Robin Sage and you're actually working with the other MOSs and you get to learn what they bring to the table. But there's this idea that the medic's the smart guy on the team.
Yeah, not always true.
Not always true, but I'll say more times than not, it's true, and might be the weird one on the team.
Yep.
That's sometimes true.
That is very true.
More than not. But what was your maiden MOS, your initial?
When I came in the Army?
Yeah.
So I was a 19 Delta when I enlisted in the Army as a cavalry.
Cav Scout.
Right? A Cav Scout, Private Solheim. So, and then went to OCS and commissioned in armor. Not by choice, but by designation of the Army, and then as quickly as possible ran to the to the Special Forces.
I was 11 Charlie, and my first unit was a Cav unit.
Is that right?
And my second unit was an armored unit.
Yeah.
So,
you understand. Yeah. It's well, it helped me make the decision to come. It's not for everybody, right? So you find your niche.
it helped my wife allow me to go to selection.
Is that right? Yeah. My I guess looking back, I'd say the same thing, Rick. She's like, I need you to be happy at work, and this is the road to get there. And she was right, as usual.
Like you said, you had these preconceived notions. You go into Sage, you graduate, you go to a unit.
Mm-hmm.
I know something that's always seemed to float around is your medics can hold on to a patient for like 96 hours. How did that, even just your experience at Sage, now you have to do like real deal mission planning, actual lives on the line. Like how did that information like plug into your mission planning?
Well, as you go through the military decision-making process, I remember at Sage, maybe your experiences too, when you guys were at Rob and Sage, right? Like the Alpha, the Special Forces officer on the team is the one that gets the preponderance of training and sort of leads the team through that mission planning. But I remember as we organized that mission training between the MOSs, if we go all the way back to Rob and Sage, working with each of the MOSs and teaching them what needs to happen to do MDMP. And but I was fortunate to have good medics and I'd say a good experience where I was impressed with the people that I was working with. And so credibility of medics was good for those that were represented on my team at Rob and Sage. So yeah, but your question was specific to mission planning. So I clearly remember the officers during that portion of Rob and Sage earning their paycheck to kind of teach the team on how to do this. Cause that's what of course you spend most of your time in your, air quotes, your MOS training.
Yeah. And then you're going into like, real deal missions.
Yeah.
Like, how did that, like, when it comes to like, hey, we can do this, we can't do this. We need to put more resources forward. We don't.
Mm-hmm.
At least my experience, Afghanistan was like, you get medevac. That was the extent of it. Hey, is your aid bag packed? That was the extent of that. And like, out we go. Now looking back on it, I was like, holy crap, I took a lot of things for granted that I could do. And, bad things happen, of course. I always think to myself, like, man, could I really held on to anybody that long? And that's a great big question mark in my mind. Luckily, of the injuries we did have, I was able to do it. But I could only imagine as a commander, not having gone through a year of medical training, it's really hard to know like what your guys can do and what they can't do. You're kind of just dependent on their honesty and, the battalion docs and other people advising you. I guess how did that kind of information go into what you could do, to what extent you could do? And like, I'm not looking for capabilities, but I'm just like, how did the medical aspect of it weigh?
Yeah, that's a good question. You talked about go back to the global war on terror, and like, okay, what kind of environment were we all in? And I imagine at some point in this discussion we'll talk about where we think we're going, and there's a vast disparity between what we did and what we probably will need to do. And so I think we were all victim of the realities of what we were doing on a day-to-day, right? So yeah, hey, medevac is going to come, air superiority is going to happen, overmatch and dominance on the battlefield is going to happen. And so I wouldn't by any means say that we were lazy in how we all did business back then. We just did business the way the environment required us to do it. And so that battlefield and the next one will be different. But reflecting back on the last battlefield, haven't worked unilaterally with ODAs, haven't worked with partner forces, haven't worked with commandos, and then all the differences that each of those missions sort of bring. I do remember, that especially when you start talking like, hey, I'm going out with a commando Kandak, and you're going into somewhere that you're going to expect that there's going to be contact and very potentially casualties. I think reflecting back on that, we really did take the time, and I really did. You're asking me how I leaned on the medic. Like, I really did have to lean on the medic to say, okay, hey, like, talk me through the bad day. What does the bad day look like, and how do we handle the bad day, right? And so, depending on the missions that we went on, there were certainly times when I think made a lot of mistakes as a young detachment commander. Maybe one thing I did that wasn't a mistake is for those more complex missions, we actually did full ODA, MDMP, which of course, included the medic not only doing that administrative side, but hey, let's talk about medicine, let's talk about medical, let's talk about evacuation, let's talk about roles of facilities and all those things. And so hopefully there's some young bucks out there listening as you talk about it. What might this look like for you? There's a reason why we do meticulous, calculated, and systematic processes to planning and bringing the team together, because that's how you make sure as best you can you don't miss things that are important. And in this case, medicine, obviously, really important.
That's how we bring our guys back.
That's how you bring your guys back, right? I mean, we may get to a point of talking more about that, but I think I told you something I did right. I'll tell you something I did wrong. We did not spend enough time making sure that the team was capable of all of us doing the things to save ourselves or save others. We just sort of relied on the medic a little too much, and it nearly cost me my life. Yeah, maybe we'll come to that later.
Yeah. I mean, I don't know how much experience you had as a team leader with the battalion doc, but like when would you reach out to him to say like, hey, like what resources can we put forward, or what do you think about this? Are the medics capable of doing that?
As a team leader, didn't even really know what he did at that point. I was too young, and
Do you think you should have?
it certainly wouldn't have hurt. Yeah, I mean that's a resource, right? That's a battalion special staff, but those docs serve the ODAs and the companies, right? And so
They're supposed to.
that's right. A good one.
Yeah, a lot of them do.
Exactly what they do, right? It's not just about. Well, in this case, it's about making sure the medics continue to be sharp at what they need to do. So, to answer your question, yeah, I would have loved to have known what I know then, what I know now, but you know what? I've seen good battalion docs that understand maybe the detachment commander doesn't know everything he needs to know, and so they're a little more experienced and can lead and guide. But as a battalion commander, much different relationship with that battalion doc.
Okay. Kind of leading into, you mentioned, being wounded. One, like, obviously was a horrible experience, but like, did it go smoothly? Do you feel like as smoothly as expected it should be? Was everybody kind of on point, or was it just kind of chaos?
In combat, even things that go well,
Yes.
chaos,
Yes.
This night was no exception. So I can, with no reservation, tell you that I am only alive because of 18 Deltas, period. And I will show my cards a little bit and say, hey, here's where I failed myself and probably others that night when I reflect on some of the training we probably should have done before. But I was, severed artery in my leg amongst other pretty significant injuries. And, don't have to tell two medics, clock starts pretty quick when you arterial bleed out of your leg. And it was the, it was the two medics, 18 Deltas, that, exposed themselves to fire to come to my aid. And like I say, without question, stopped me from bleeding to death in the street. And if I take the whole journey, we're talking about medics, but if I just look at the Army medical system from launch stool, from the green zone in Iraq, let's even go further, from the battlefield, from the streets of Karbala to the green zone in Iraq, to launch stool Germany, to Andrews Air Force Base and Walter Reed, I felt extremely lucky and in good hands at every phase of my recovery. Very few exceptions. No matter how good something is, somewhere you're going to find somebody that there's going to be, I'm going to do my ice complaint on somebody, right? But I say that jokingly, but I had a tremendously positive experience, And I was at Walter Reed in 07. And so 07 to 09, I spent a lot of time at Walter Reed. But very good experience. And it started with the medics, right? So I wouldn't even have had the rest of the story if medics hadn't done their job. Did exactly what they were supposed to do under fire. And so I owe those guys my life. I really do.
Yeah, very good. Now, you mentioned, training that you had wanted to do or should have done. Training is another thing that medics pretty routinely complain about, especially working over at the refresher courses. From being the team leader or maybe even at the company level, was the initial training, the refresher training, did you think that was sufficient? Did you think that was like too much time away from the team? They needed to be doing other stuff? Like, what was kind of your impression of that?
I'll be honest with you, back then, I just knew the medic had to go do this stuff. I didn't really know what they were going to do. It's like, yep, okay, here's a slide when we go into, the company training meeting or command and staff, right? Okay, medics need to do this stuff. So back then, I'm just making sure they get to where they need to go. And so, yes, especially the 18 Delta has these requirements that nobody else has, and I think it's a challenge for Deltas. I think it's a challenge to be in a highly trained organization, which really defines what SOF is, no matter what patch, hat, or tab you wear. But the unfortunate thing of doing high level tasks is typically they're all perishable, and the medic clearly is no exception. So we call him a medic, but then giving you a casting a wider net and answering your question, Dennis. But I can, whether you're Charlie, Delta, Bravo, whatever, you've got this long list of things that you have to be good at, right? I've got to maintain my language capability. I've got to, if I'm on a specialty team, I may have to, it's free fall or dive or a team needs to go to Cephalic. I don't have to tell you guys, individual schooling, all these things that are required of us, all of which require you to continue to sharpen the iron at those skills. So now being on the institutional side of this as opposed to the operational side, I respect what is required for a medic to keep their skills up. And my perspective from where I sit now is, and let's divide this up, operational and institutional. If those things are operating right, when I say operating right, I define that by the organization is facilitating the things that a 18 Delta, if we're talking about them, they need to have to be able to, we owe it to somebody to give them the resources they need to do it. I think back to when I was, much younger, we were all younger. You remember to keep your language up. It was kind of your responsibility, right?
Yeah,
I got to test out, but it's up to you to keep up your language. And now there's resources for guys, active duty guys, to be able to go. I've got to take a test, so I have resources available to prepare me for that. I think that's just a good illustration of the same with the medics. The architecture's in place. If we utilize it right on the institutional side to hone the skills and keep the skills sharp of our medics. And I like what Rick does in his course of bringing people back from all different military backgrounds and share experiences and okay, hey, this is not only are we going to re-blue you in these civilian certifications you need and your ATP, but you're also going to get to share experiences from people that are doing this in all different AORs and all different professions under all sorts of different banners. So I think that's great. But I also feel like there's a operational force responsibility and an individual responsibility. And I think when we assess and select people, we are looking for people think, that have that sort of drive and understanding that, like, this isn't on everybody else to keep you good at your job. We need to wake up every day and continue to be good at this, because teammates require you to be good. Shoot, communicate, medicate, survive, fight. We got to be good at a lot of things. So,
yeah, there was a time where the regulatory requirements for maintaining currency were not really adhered to. They were not brief. And if nobody holds that standard, then there is no standard. And we went through that period, and then as things changed, we started paying attention to that and remembering that in the regulation, that's a minimum standard. And I know that turned around and it became more important to commanders. But I think that was a big step in the right direction. I think where we're at now is trying to influence training at the unit level. Training not just for the team, because we absolutely should do that, but training for the medic at the unit level. Because at the unit level, you're familiar with the AOR, the requirements, the resources that your unit has. So there's a onus on the unit. I mean, nobody balks at scheduling marksmanship training, CQB training, demo training, airborne ops. Why isn't this? I mean, nobody wants to do commo training. Nobody wants to do medical training. I get it. But I think there's a way of addressing that where for the team, it can be exciting, interesting, fun, and you can challenge your medics and help them be better. Not make them, but help them be better.
All right. Are you framing this, Rick? Are you thinking of it in terms of medic-led cross-training, or more like the battalion maybe is facilitating for companies and ODAs? Okay.
Yeah, a bit of both, because we've recently seen a little bit of emphasis on ODA training.
Yeah.
In special forces, because they were getting ex-evaled. They would pull the medics, they would evaluate the team, and if the team didn't do well, that's visible to the command, and nobody wants to look bad. We didn't go through all this stuff and be on an ODA to look bad. The first rule of SF, look good, right? So
that's right.
So when you look at that, so with the ex-eval, there's been an emphasis on cross training to make sure the guys are good, and it's not quite reached through all the groups, but I think it's making its way. I hope.
I appreciate what you're saying, Rick, and I actually, like, my experience, really agree with you. I told you I would always give you a kind of a bad story, and you just opened the door for me to tell it. I did not save myself on the objective. Save myself meaning, like, I'd been shot in both legs. I've been shot in my shoulder. And I didn't even know I'd been shot in my left leg, but I knew I'd been shot in my right leg because my femur was broken and my sciatic nerve was severed, so I couldn't feel my leg anymore. So I knew something was wrong. Yet I didn't put my own tourniquet on. And I, tried to relive what I can remember about that night a lot of times. But it was medics that, of course, came up, and, like, I told them, I went on the radio and said, hey, my leg's broke, I'm shot. Deltas came. But, if I use something else kind of for shared understanding, like when we go to the range, you go to Sephardic, you go to Cephalic, and you're in the flat range portion of training, or you go out with your team and just go on the range, right? We're meticulous about, if we're doing it right, how we train, limited visibility, daylight, known and unknown distances, optics training, lasers, touch points on your equipment, slide lock reloads, tack reloads, all that stuff that you and your listeners are probably familiar with. Do we put the same emphasis on other things, like, if I use my own example, where is that when things go bad and my faculties aren't all where they should be? do I go through that personal battle drill of self-aid? In my case, I didn't. I look back and go, why didn't I? Like if I reverse engineer my problem, is because I didn't practice that. By the way, there was times when I think team leadership owns this, right? Master trainer is that team sergeant on the team, and team leaders there to kind of guide the longer plan, and then the team sergeant does the day-to-day business and gets things done. But where did I fail to make sure that we get good at all the things that you need to be able to do? And I think medical training, everybody's got to be just really, really good at the basics. You got to rep the easy stuff, rep it. I think the difference between sometimes like if you take a traditional conventional infantry platoon and a ranger platoon, the ranger platoons, nobody would argue they're better infantrymen because they train harder. They spend more time doing those basic skills. So I guess I'm speaking to everybody out on this podcast who finds himself in either as a medic on a soft team or something like that, or you're an NCO that's leading training or a master trainer. We need to think about those things. So your point's well taken, Rick. Cross training really matters. And I don't care what your budget is. I don't care. Like, you always have time to do the little things. And in my case, not doing the little things, that was literally the difference between life and death. Just happened to have teammates, but if those teammates had been 4 minutes away, we wouldn't be having this conversation. Okay. But if I had just trained that simple thing, that battle drill, what are battle drills? Just things you just do. If I get ambushed, I know what to do because I've gone through it and I've practiced it. I don't have to think about it. We need to be that way with a lot of things. And I would say clearly medicine is one of those things.
So I tell guys all the time, I said, if you get injured, what's the one person that I guarantee is there that can help you?
You yourself, right? Yeah.
You're there. And if you're conscious, you're the first person that can help you. So when we start cross training, that's where I usually start. I recommend new guys when we mentor them. Hey man, start with how they can help themselves, self-aid, and then you move on to buddy aid, how you can help somebody else. Then you go on to how you can help me if I'm hurt, so medic aid, and then you go on to figure out who is going to help you if you have a prolonged care or multiple casualties or whatever, so there you can pick guys who have a little bit of an aptitude or whatnot, and you can train them. So that's how I recommend new guys look at setting up cross training when they get to their team.
Yeah, no, I get back on a team together, Rick.
Yeah.
The team be in good shape.
Hey, I used to tell my battalion sergeant, he was a big runner, and I was always middle of the pack guy. And he's like, hey, you need to get out with your team and run more. I said, Sergeant Major, running breeds cowardice. If I can't run, I got to fight, right? And he did not agree. Interesting times.
That's right.
Yeah, but I mean, I think, especially like training that we've done on the calendar, hey, we're going to spend 3 days on the range. We're going to go do a 2 weeks of FOWIC. We're going to do et cetera, but we like binge and purge our training throughout the year, and we don't think about that again until next year or next cycle or whatever, but I tell the students, like, the basics are simple. Like, in the time it takes you to go to the bathroom and come back, you can put a tourniquet on. You can do that 3 or 4 times. Like, if you did that once a day, how friggin' awesome would you be at the end of the month? It takes, how long does it take you to do an IV? 5 minutes. Okay. Well, if you spent 5 minutes once a week on doing an IV, that's 52 IVs in a year. That's 104 by the time you come back to Sockamus.
Probably not missing many IVs.
Probably not missing that
Not
many
missing many
IVs.
IVs. No.
And you've spent $40-$50 worth of IV catheters. You know, I'm willing to bet the military, I know Doge is going on, but I'm willing to bet the military has $50 to spend on a medic to be really good at a basic thing, that if he can't do it, absolutely nothing happens after that.
Yeah. Yeah. That's, no one will argue that it's difficult to, we talked about perishable skills. No one would argue that it's difficult to keep good at everything all the time. So as people build those quarterly, annual training calendars, right? I mean, I think you ebb and flow with what you're going to be good at and when you're going to be good at, and what things do you focus on based on where you're going, and what's the next mission, what's your higher headquarters telling you you're going to do. But yep, it's difficult. But man, if you've got, in my experience, if you've got a good team sergeant in that team room, you're going to get it done. Training is going to be worthwhile. You're going to train hard, and it just takes good master trainers to prioritize the right things and get it done. But it can be done.
So one of the things that I found over the years is that I was sitting at a bog sat. I don't know if you know what a bog sat is. Yeah. Bunch of old guys sitting around the table. So one of these big meetings, there was this doc. He's like, hey, you want to teach your guys this skill set. How can you maintain that skill set? You can't maintain it. There's no way. You've got so much going on. I'm like, you're absolutely right. I don't give a crap about maintaining the skill set. What I want is a way to train up before we deploy with it. If we're going to use that skill set, then I want a ramp up, a train up, so we can dust off, because there's just too many. 18 deltas, the critical task list is so long, it's ridiculous. However, it's so broad that because the mission set's so broad. So you need to pick what skill sets are important for this coming deployment. You do your best guess, and then you train up those skill sets. You take them down, you come back, and then you get ready for the next one. You train up different skill sets. And it's not just medical. It goes, I mean, we've seen over the decades, all the different, that's what I liked about SF is it was always different. You're going to go down and teach peacekeeping operations to the Bolivians. What do I know about peacekeeping? Well, you're going to learn, so we can do the same thing with the medicine. We can pull those skill sets that we think we're going to need and we want to focus on and train up on them. And then you have them when you need them.
Yeah. And I think like right now, like the JTS, other echelons above on the medical side, like their kind of push or the thing that they would like to see happen is take the 18 deltas out, not necessarily out of the team, but put them into medical centers so that they can be medics and think medicine more frequently. I'm not really certain if anybody actually talked to the operational side, if they're down with that. So let's say, the medics are going to spend half their time in a clinic or at the main hospital. Like, I guess, what would you think about that?
Well, if I were asked to make that decision, so if I understand what you're asking me, like if you were to do clinical rotations more than we already do, I think the most valuable time you can spend is with your team. Unless you're, like, let's say we're in a cycle of individual training where everybody's going to their schools. You're going to the dive school. You're going to Sephardic. You're going here, whatever. Your individual education, but maybe there's a place for that. But if you had to choose, I think the better place to be is a team. And by the way, our institution, we already have opportunities for guys, medics, to go do, I think, valuable rotations, whether it's when you're in our courses here or when you're out in the operational force. We get you back to do those, I guess maybe to kind of re-blue in that clinical side of working in a hospital with patients and things like that. So I think we already kind of have that.
Are you talking outside MPTs or
No, I'm talking MPTs.
MPTs? Yeah. So 2 weeks every 2 years, 4 weeks every 4 years?
Yeah.
I can tell you every MPT rotation I went on, I learned a lot. But I did in my career, I did 3. Each time I worked a lot of hours. I learned a lot, some really good people, really great experience, new procedures, new drugs that I wasn't tracking because I was in, when you're on a team, you're doing team stuff. So got a lot out of it. But on the flip side of that, I don't know if there's a way of doing a better balance where instead of 4 weeks every 4 years, breaking it up so you have a little bit more frequent exposure and kind of balance that out without depriving the team of their medic for an extended period of time. Because when we set up the SFMS skill sustainment, that was the big thing is we wanted 3 weeks instead of 2. And we had commanders that were like, you're going to take medics away from their teams for an extra week. Yeah, an extra week every 4 years. It was a big fight. But in the end, I think it's kind of worked out. And now it's just kind of an established thing. But I don't know if we could do something like that, if it'd be possible. Like the Navy has a model where the medics are truly under the provider. And he is obligated to work with them. They're supposed to do clinical time together. So I don't know how that would work with within the SF confines, but I don't know if you have any thoughts, any familiarity with how the Navy does it.
Well, it's about the extent you said we're seeing the SOIDCs here and the capabilities that are slightly different than ours that they have, or maybe that capability is not the right word, but what is the right word? The access they have to and the what they can do, is different. It's modeled different in the Navy. So, perhaps that's something. I guess we could make the soft side skill set's the same, right? SOIDC or 18 Delta has the same skill set. It's just how we determine we're going to apply those into the. And I think the Navy is driven the way it is just because of the environment that they're working in on a fleet. But,
I know like 15 plus years ago, we tried through the Army system to get 18 Deltas, nursing privileges, access. You could order stuff, you could do all the things, and it had to be countersigned by a licensed provider, by your provider. Sure. And we just could not make that happen. We could not, the bureaucracy beat us down. And we just could not get it across the finish line. So I don't know. I'm hoping that somebody else tries and they're successful. It'd be nice to.
Well, I think AMED and those other strategic level medical things are definitely changing their outlook on, like, before maybe GWAT. Being a medic was cute. Like, medicine. I'm glad you think you do. Yeah. So when it came to, hey, we want to be in charge of all our narcs, we want to write soap notes, we want to, there's, it's going to be chaos. Like, no, no, you're not. However, GWAT going forward, prolonged field care, prolonged casualty care, like that's a real thing. And that's actually penetrated super deep into the culture. Doctors, surgeons, etc., like they recognize, like, hey, like we are expecting these people who get an entire year of medical training compared to a surgeon who gets almost a decade of medical training. Yeah. He's going to have to do the same thing in the freaking dirt by himself. We're going to have to, we have to give them experience in how to make a medical decision that's not throw a tourniquet on it and get them to me as quick as you can. They're going to just be expected more. So training and exposure to things it's just going to have to happen, or otherwise we're just whitewashing the actual problem, which is not good. right? So, you've done your operational time, team leader, company, battalion, company, that's when you were wounded, your recovery, and now you kind of go on to like higher command level things, strategic level things, and then you're coming back. So you have this like accumulation of knowledge of, hey, this is what I was told, this is kind of what I've experienced. Now I got firsthand experience with me on the battlefield. Like, how did that change your perspective at all? Did it just inform your perspective? Like, I guess, where did medicine rack and stack after your injury versus before?
That's a good question, Dennis. I got to think about that. I think not that I didn't understand the value of the medic, right? Because I've seen them save other people's lives before they saved mine. But I guess a renewed respect for medics after my own personal experience, and more broadly, I guess, renewed respect for kind of the brotherhood that you sign up for in all of this, right? Our creeds and the things we say to see people do them is a whole nother level. Not to recite it, but to do it. So I think, sure, yeah. I mean, afterwards, obviously, I held the guys that saved my life and the MOS that they had with a great deal of gratefulness and respect. You asked maybe how that changed things. I think that a lot of things changed for me after being injured. Your perspective on all sorts of things changes. Specific to the medical field, I don't think I underestimated the value of our medics prior to. They just lived up to that, right? So you lived up to it when the time came, and I needed you the most. But I can tell you, over the course of my time overseas, I was often, if enamored's the right word, maybe, when I watched what our medics would do. Whether that's treating an illness in a host nation person, whether that's treating an injury, whether that's treating wounds, whether that's saving lives. The same things I see when I walk to the back of our building here and watch training happen. You see that, to use words you said, Dennis, in the dirt. I get to see what the training, the job I'm in now, I get to see how we make those guys. I did this backwards, right? I get to watch the end product do the job, but then I come here and see how we build that product. Now, have a greater understanding and appreciation of what it takes to become any one of the, folks that get the new ASI or get the MOS. But I don't know if I'm answering your question very well. I just, we could talk all day about how being very seriously injured, almost dying on the battlefield changes a lot of things and perspectives in your life, and how you soldier, and how you, frankly, I think you do everything, how you father, how you live your life, the things that you worry about, the things you don't worry about. And, I think when you lead others after an event like that, you're more methodical on the medical side about, like, hey, ready for the bad days.
Yeah, I mean, I've never been on a command team or anything like that. It was just always just regular ODAs. So I never got to see that side of what really company and up, how that functioned. But I could only imagine, after an experience like that, you hold on, as in a battalion or group, etc. You know exactly who your battalion doc is, and you probably, I would imagine, bring him into the conversation a bit more, not because you forgot about medicine or you forgot that it was important, but it's more like, have we done the best job we can? We kind of assumed that we were doing all right. Can we be better? Did that come into play, or did you kind of already have it?
Well, I'd like to think I had it, but yeah, like, are you doing everything you can to make sure? I guess sometimes we think about medicine, particularly when we're talking about deploying in a hostile environment. Like we think about that's sort of when things don't go as planned. We need to put the medicine piece into this, and then there's all these other things that we do in mission planning, and then there's the medical side of this for the unforecasted, unplanned events that may occur. So yes, I think when we specifically think about mission planning, and you're talking about a level above the ODA, definitely always thinking about are we doing everything we can in all the areas, right, to make sure that there's mission success and you're taking care of whoever out there on the front line doing whatever business needs to be done. And then you talked about the battalion doc. My own modus operandi was really the special staff. I'll say all three, very, very close to those guys. And in my opinion, in my experience, if you don't use those guys, then you're crippling a resource that you have. Like, as the battalion med is a significant part of that. So you need a good doctor on your team, that he pulls his weight and brings his game, and then coupled with an environment that allows him or her to be able to do their job well, which in turn means that the medics and the teams are taken care of. I mean, that's what we all exist for, right? It's the guys down the hallway. That's why when you get to that level, that's what matters.
What did you, as a battalion commander, group commander, what did you expect out of your med section? Other than med pros.
Yeah, other than med pros, right? Being deployed, of course, it's when you talk about planning, if you're not something at the ODA level, right, but something higher, maybe company op or something, or are we doing all the right things? Are the different roles and facilities in place? Is there a forward surgical team that needs to go somewhere because we're expecting casualties, and that's the way we're going to make sure they come home? That's on the operational side. I think on the training side of this, especially in the world we live in now, where we're not necessarily deploying to places that are all kinetic, is the doctor resourcing the medics to train themselves, train their teams, and have the resources available to do that. To me, that's a big part, not the med pros, but that's the big part of one of his big roles, is to make sure like you're carrying the weight of resourcing the guys to be able to get things done. And I do think there's an operational requirement that we have to make sure people know here's what you need to be good at. Here's the things that I need to give you to make sure that you can be good at those things. So relied a lot on the battalion doc to be able to do that. So, and I think battalion docs need to know that when they come in. Like this is a big part of your role here when you come to a special forces unit, enabling those medics.
The whole idea of the structure of battalion med, the docs, they bring the medical knowledge, but a lot of times, they come from conventional medicine, and there's a bit of a language barrier. So you've got a senior medic there who comes from a team. There's a reason it's an E8 slot, but it's usually not filled by an E8. So you've got a guy that can talk to the teams, that can talk to team stuff, and run the trackers and brief the command and all that, and advise, and he's going to try and mentor and advise that doc. Because at the battalion level, that's the first time you have a provider, a doctor, assigned to the soft unit for SF anyway. So you have that doc there, and then you've got that medic, and sometimes they don't speak entirely the same language. If we're talking medicine, sure, we find that medical terminology at common ground. When we start talking about operational stuff and requirements and tactics, there's a lot lost in translation. That's why we have the PA. PA is often, a former team guy that went to PA school, be 18 Delta or whatever, and he got to learn some of the medical, how medicine runs in the regular Army, and then he's come back, and so he can be that buffer, kind of like the warrant on the team between the team leader and the team sergeant, that tiebreaker, and so I think there's a lot of potential in the structure and how it's designed. It's implementing and having good people in there. I think that's key. That's the winning ticket right there.
It's always the people, right?
Yeah,
it's
it is.
Always the people.
It is.
Yeah, and that's a good point. And not all docs maybe understand. They'll learn, but they may not understand when they show up the capabilities of the medic. So I think if they don't come with that knowledge up front, there's some trust that has to be built for him to realize, man, these guys, I don't know what happens to JSON on TC, but.
Well, here's a shameless plug. There's a USASOC policy that says that within 6 months, any provider in a soft unit needs to go to one of the sustainment courses, skill sustainment courses, and audit. So 2-3 weeks, doesn't matter which one, but they're required to go there. And that's why we put it in the reg years ago, was to have them come down there and see what their medics go through. At least I know we can't have them go through the multi-month, the year-long training and all that, and that would not be a good use of that physician, but to have them come down for 2-3 weeks and audit and see their medics perform when they're being evaluated, when they're doing their thing. And I think it gives them a better appreciation. And then we don't have some of the things that we've seen in the past, is where you have a provider that is very disconnected, and it's kind of frustrating. I went up and I had a provider kick back my med order because there were pediatric drugs on there. He said, "You're not authorized to treat kids." He said, "I'm a family practice doc. I'm not allowed to treat kids." I'm like, Are you kidding me? I'm going to be downrange. They're going to bring me kids. If I don't have drugs for the kids, what am I going to do? We lose rapport. So having that, those little snippets, those little learning the training, the skill set, the scope of practice of your medics, and what is expected of them when they deploy and when they go downrange, gives that provider a little more comfort in allowing some of that stuff that he maybe isn't as familiar with himself, or he's not comfortable because he's thinking 68 whiskey, maybe, regular Army medic, which are great, but they do not have that year-long training that our medics get. So when you look at that, having them understand the training, the scope of practice, and probably most importantly, the environment that those guys are going to deploy in, and how they're going to do medicine, be expected to do medicine in that environment, I think is really key.
I mean, I think it's absolutely crucial.
Yeah.
I mean, it's one thing to be able to, I can't really do it that way.
I've heard providers say, "Hey, that's not the standard of care." And I'm like, you're right, it's not. Standard care is me to get him to you in a brick and mortar hospital. Can we do that? No. So now I'm going to do the best I can. And you're right, it's not the standard of care. It's the best I can manage in these conditions. And I'm going to do everything in my power, because I don't want to carry that weight of not trying and failing. And
well, that's a challenge for the docs who might listen to this too. Like if you find yourself in soft units, it's not a good idea. I as a former commander in the operational units, would say that's a responsibility, because if we don't have a shared understanding of capabilities, then we limit that resource.
But you lose that capability because the provider limits it because he doesn't understand, and that can lead to bad outcomes.
Sure.
Yeah. Yeah, I would almost one up you as far as saying any provider that's in charge of anybody who's not a provider in an austere environment, if you don't know that environment inside and out as well, you're an absolute failure. But I'm harsh. Speaking of harsh, going forward. So now you had your experience of your career. Now you've gotten to not only see behind the curtain, but actually be the curtain at the training courses. What insight have you gained? What would you tell past you about, hey, this is the kind of people you're getting, this is what they're capable of doing? And now also being able to look forward, like, it doesn't look good. What do we need to do to get people ready for that?
So coming here, I'm if you didn't go through this school, nobody really knows what goes on inside these gates. And so, and for the listeners, I have no medical background. So coming in here, I think it only reinforced my perceptions about what medics can do. Reinforced probably isn't a strong enough word. It increased maybe even increased isn't the right word. I'm trying to think of the right word, but it boosted significantly my impressions of medics. And whether that's you just going to the Special Operations Combat Medic course and what those whiskey ones leave here the capability to do, or then, for those that continue on to the MOS courses, like our 18 Deltas, SOIDCs, our 38 Whiskeys, I am impressed, have been impressed, and continue to be impressed with what we do. And I think shout out to our instructors here, the professionalism of the team that's been built here, the dedication they have to actually believe in this mission and say, hey, what we're doing is really important. Everybody shows up here every day with that attitude. So it's a place of a great deal of value. But for me, as having never gone through this course, 28 years of my military career, never stepped foot in here. So the last 2 years, it's great to be able to see and watch and go, okay, I feel good about the product that goes out to the operational force. I feel like the team downstairs creates a product that is what is needed in the force. So you kind of led into, Dennis, like, okay, what would I tell guys when I think about what's next? I'm under no illusion that it's hard, I think, for ODAs right now, because you're splitting what you're thinking about, right? There's the mission that you may go to in said continent that requires you to do certain things, but then we also have this more ominous and complex problem that we title large-scale combat operations, or things that could go on right now in other air wars and things we're worried about. And so I'll go back to one thing I said earlier. I think the thing that makes me believe in the ODA, or units like the ODA, depending which service you're in, select good people up front. We select the right people. We give them world-class training. And they're good because they continue to be good at they're smart and they're good at the basics, right? And so I think of us as this modular capability that can go do things different places because we've been given the ability to think, right? Yeah. And couple that with things like you walk out of this school with, and take all the MOSs, and you've got this magical thing called the ODA. So put us where you need, and we'll get the job done. Now, why do I think that's important? Well, we talk about this. What I just mentioned is the division of things ODAs have to worry about. So, old Kent would tell young Kent, probably the same message, like, be really good at the basic things. rep them, do them over and over, because the good thing about the basics is they'll probably apply to a lot of places. I can put a tourniquet on in the Indo-PACOM theater, or I can put one on in Southcom's AOR.
Your legs shaped the same.
They're shaped the same, right? But I think old Kent would also tell young Kent, like, I will say the luxuries of warfare that we've had over the past 20 some years, they're gone. In reality, if we go to, unconventional warfare that became foreign internal defense and some counterinsurgency, the things we did, we look at what industrial warfare and the future battlefield will look like. It's a scary place. And so how does a medic deal with that? So when I talk about taking things for granted, keying a radio didn't get me killed in Afghanistan or Iraq. I didn't worry about drones. I didn't worry about massive artillery. I didn't worry about the fact I knew that a helicopter was going to come if I got hurt. And so I just used those few illustrations about a week ago, this long list of things that's going to make the complexities of the next battlefield so much different. And so the thing that keeps me up at night when I think of our medics is like, are we preparing them to be able to operate on the fringes with all the complexities we just talked about and accomplish the mission and take care of your team? So if I asked that question to myself, I would say that I don't think anybody does it better than this institution, bar none. And we say we produce the world's best medics here, special operations medics. That's not a slogan on a t-shirt. We all come to work and we all believe that. And I think the threat of what warfare could look like becomes part of our motivation for what we do here too, to say, okay, had we given this young ranger, special forces medic, or name the constituent that comes through here, have we given them the ability to do what they need to do on the future battlefield? I would say we have. But when you leave here, don't let your powder get wet. Don't let your blade get dull. You've got to be sharp. And then full circle on this conversation, your team has got to be sharp. And there's no excuses in our business to not be good. Like I think to myself, like, we get paid to stay ready. We don't get paid to get ready. Some other organizations and units might have some luxuries like that. We don't, right? And so that's the mindset. And for the listeners out there that think about, hey, is this business for me? I would say, if you thought about doing this, bring your A game. It's going to be, this is an academic juggernaut. It's a tough course, but this is where you play varsity. If you don't want to play varsity, you want to play JV, play JV. If you want to play on the varsity team, this is where you come. If you're hungry to do medicine at this level with the best, this is the place to come, right? And so much is given, much is expected. So show up ready. Probably going to go through an assessment selection to get here, but looking at two guys across the table that did it, I don't think you'd change anything about the path you chose. Nope. And I'm one limb down, but I wouldn't either. But we've got to think about some tough things in the future. I think almost, I'm going off the beaten path a little bit here, but I think there's a paradox too. And when I think about the future battlefield, I talked about keying the mic, right? Keying the mic might get you killed. And it wasn't about 6 weeks ago. Somebody put a picture up on the screen, and it showed trench warfare of the World War I, and then right next to it, it showed a picture of Ukraine. and I wore a color photo and I didn't recognize the bump style helmet, I mean, you could easily put those in black and white and confuse those two pictures to be from the same conflict. Yeah. And so I'm reminded of the fact that some things just don't go away. Mm-hmm. And here we are, we're seeing trench warfare, we're seeing artillery causing mass casualties. Yeah. And so the paradox I'm talking about is maybe it's the simple things that in the complexity of the next battlefield, it's the simple things that will keep us alive. It's putting your camouflage on like we used to do, right? Taping your ring because someone might see it. I'm just using some
taping your dog tag.
Yeah. I know it sounds silly, right? We're talking about some old stuff that a lot of listeners wouldn't even know what I'm talking about right now, but, it's those simple things that might just help us survive the complex technical environment that we're going into. So be good. Kent would tell the young Kent, be good at the basics. And, they will serve you well, I think, in things to come.
Yeah, we've got a saying, if you want to learn something new, read an old book. So trying to look forward. Reading about World War I, World War II. So World War I, the new thing was massive artillery. That was and we're seeing that with drones now. There's a kind of a correlation there. And we look at the war in the Pacific with the tyranny of distance. The lack of air superiority and the delay in getting patients out. These are things that are potential for future conflict. But what doesn't change is the medicine, what the patient needs. You need to stop the bleeding, get him behind cover, get him, stop him from getting injured more, and then assess what he needs and start giving them what they need to survive, and then getting them evacuated when you can. If you can't, you have more work to do to keep them alive. So it's kind of staying with, medicine's medicine. It doesn't change. The environment you do it in changes. And exactly what you said about cross-training. And that's more important now because your medic may have a hard time getting to you in the current environment as opposed to when you were injured. Even then it was, I'm sure, very dangerous to come to your aid. But here with drone warfare and all that, it can be even more so. And having the cross training and the buddies taking care of each other, that whole aspect of it is a means to increase the preservation of life on the battlefield.
Yeah, and I think, we say prolonged field care. I mean, I think a lot of this is prolonged field care under fire.
Yeah.
The reality is that just may be the way that it's going to be. And evacuation is going to look different. We haven't even talked about things like, I don't know, like sickness.
There's going to be more cops.
Yeah.
Yes.
Like malaria. I'm going to lose more guys if I, potentially, when I say lose, meaning like combat power from illness, than I might lose from battlefield injuries. So, do we need to know a little about that? Yeah, maybe. Maybe I need a little, know a little bit about that. Or if I can't get people back to a Roll 2 facility and a guy blows his knee out, maybe some of those little things are going to be important too, because I think, casualty numbers we expect will be different. So combat power on the front line is going to matter. Not that it always doesn't, but will particularly matter in a place where maybe you don't get many people behind as you're used to. And so are medics prepared to care for those more unique types of things that can take combat power away, and then understand that you may have that injury or illness from cradle to grave? I don't literally mean grave, but I mean start to finish, right? And so, yeah, I think we talked about the simplicity, but there's also some complexities that come with what medics may find themselves dealing with.
Yeah, the DNBI,
Yes,
disease,
DNBI,
battle
exactly.
injury.
Yep.
And a lot of that can be, to a certain extent, mitigated with preventive medicine. So I always said I was a lazy medic, so I practice preventive medicine so I don't have to do real medicine because, that's challenging. So yeah, we would do PM stuff. But then, I've had people ask me, like, why do you spend so much time on trauma when like 70, 80% of your medicine is DNBI, sick call type stuff? Like, well, that's easy. The trauma stuff, the clock's on you. The guy dies. He's actively dying. You have to stop him from actively dying. And the clock's on you, depending on how injured they are. So there's a sense of urgency. There's those battle drills, those rehearsals. You need to just be able to do it in the dark without, being able to see, with just by touch, to do these things. And for sick call, most of sick call, I can look it up in a book. I have the time, I do my exam, I look it up, I can visit a reference, and on a good day, I can call someone. And, but when, you're in that ditch and the bullets are zinging overhead and, you're doing the thing and this is your buddy, there's nobody else. There's nobody's there. You're not thinking about evacing the guy. You're thinking about, oh crap, I got to stop him from dying. And we'll worry about the rest later. But let me stop him from dying. And then you go into like, okay, let's get to a safer place. And now, okay, is there anything else going on? What does he need? It's all about problem solving.
Yeah, adapting. You mentioned, teaching somebody how to think. I think that's probably the best thing that we can do. It's not, you think this, like that's like your initial training. A plus B equals C. After that, then you learn why this is not so that you can be smarter and win trivia games. It's so that when those two things aren't, A plus B doesn't equal C, well, how do you think around that? Because you know the system. What does the patient actually need? Sometimes it's not what the algorithm says.
Or your widget breaks. So you have a widget, it's measuring something. So what do you do with that data? How's that affecting your treatment? And then knowing the physiology, getting back to knowing the physiology of things, how things work. Why did you need that? Is there another way to get that information? Those are all things that we expect our medics to know, and that's what the courses are all about, is getting them to that point where we train them up with all the stuff they need, and then we start taking things away, and we see how they work around those deficiencies and how creative they are. And to be honest with you, as old as I am, you think, holy cow, that guy's seen everything. No, not even close. These guys continuously will surprise me with some of the stuff they come up with. Like, that's genius, brilliant. It's amazing.
Yeah, absolutely. I'm always surprised at some of the things that happen.
And then sometimes, on rare occasions, surprised in not such a good way.
Yeah. It goes both sides of the street there.
Well, we did, you just too, we categorized, DNBI, we categorized, injuries, we categorized trauma. The good news is, right now, the way we train our medics, they're learning those things, right? Especially, I think about some of our, like our 18 deltas in the course, and you talked about algorithm versus, I think, systems thinking in that. For a non-medical guy, I feel confident that we are training those things, that our medics are leaving here with the capability that if they do find themselves in an environment, they have the tools.
Yeah. Yep, I think so. So since we've gone like the whirlwind through your entire life and your thoughts and your pontifications on things, is there anything that we didn't cover that you think is important to kind of break down this miscommunication between medical and operational?
Well, I think maybe just to summarize what I said and recap, because I think it's a good message for listeners out there that find themselves in these positions, right? But when I say these positions, meaning like a leader of these organizations, whether it's at a team level or higher, or whether you're a medic, there's a division of labor, there's swim lanes of responsibility. And I think of the individual, we understand with perishable skills, individuals have a responsibility to continue to hone your skills. The institution has a responsibility to do like we do and provide a place to come back to and re-blue the things that you need to be good at. And then for the operational force, I don't think it can be understated enough to say there's a responsibility there too for the individual, the team, and the medical professionals and commands at those levels to say, okay, we have a part of making sure that our medics are as good as they can be. And the visits back to JSOMTC aren't the only opportunities to get to continue to refine what you do. A lot of this can be done in the operational force, and so to our battalion docs out there and our commanders, don't forget about this medical training. I guess use my story as a petri dish of what could be, and so thankful that I'm here talking to you guys because good medics were there.
Well, thank you, sir. I really appreciate your time.
Thank you much.
Yeah. Thanks for having me.
For today's podcast, make sure to go to our website, www.prolongedfieldcare.org. Check out our free downloads and a ton of other helpful information. Grab a bag of our fresh roasted PFC coffee, links in the description below, and stay on the bleeding edge of combat and austere medicine. This is Dennis for the PFC Podcast, out.